Great, thanks for all of you for being here. We're going to go ahead and get started today. So find a seat for this exciting session. My name is Ann Blaze. I'm a medical oncologist and the Director of Cancer Survivorship Services at the University of Minnesota, and I'm thrilled to be part of this session today called Living with Metastatic Breast Cancer. You'll hear the energy of the speakers that we have planned for you today, really talking about a topic I'm very passionate about, and you'll hear their energy talking the same. We've set up a series of speakers talking about early palliative care, about support for patients with metastatic breast cancer, talking about some of the logistic and financial toxicities, and then you'll hear from some patient advocates who are really dynamic and passionate about why do we need to be talking about this, helping people to live well after a diagnosis of metastatic breast cancer. We'll go through our talks with a couple of questions after each speaker, and then we hope to really have a robust discussion at the end. So without ado, I'm going to invite up Dr. Tara Kaufmann, who will be speaking on early palliative care. Dr. Kaufmann is a board-certified medical oncologist and palliative medicine specialist who really specializes in treating patients with breast cancer. She's an assistant professor in the Department of Oncology at the Dell Medical School at the University of Texas at Austin. She's earned her medical degree and training at a variety of different institutions across the country, and it now serves as an innovative faculty member. After completing her fellowship, served as an innovative faculty member with the Penn Center for Cancer Care Innovation. Her research focuses on improving supportive care services for patients with cancer, using patient-reported outcomes to monitor patients for unmet palliative care needs. And we're really thrilled to have her here today. Please welcome Dr. Kaufmann.
Thank you. Good morning. It's my pleasure to be here today to talk about early palliative care for patients with advanced breast cancer. As you heard, I'm a breast medical oncologist and a palliative medicine physician, and my research focuses on improving early palliative care for patients with advanced cancer. So this is a topic dear to my heart. Let's see. So today my educational goals are to give you an overview of the field of research of early palliative care in oncology, discuss considerations specific to patients with advanced breast cancer. I'm then going to touch on major concepts that focus on future areas of clinical innovation and research for early palliative care that I think are particularly relevant as we think about how to best do this in breast cancer. And then I'll close with practical tips for breast oncology teams for where we can start today to start to deliver better early palliative care for our patients. So I'll start with a well-accepted definition of early palliative care, which is distinctly different than hospice or end-of-life care. Palliative care is a type of medical care that focuses on treating people living with serious illness, which by definition is all of our patients who are living with advanced breast cancer. And it's truly a philosophy of care that focuses on providing relief from the symptoms and stress of serious illness, and the goal is to improve the quality of life for both the patient and family. And this is a really critical point, that the patient and family are the central unit around which all palliative care revolves, and palliative care interventions address unmet needs of the patient and also of the family and caregivers. Palliative care is provided by an interdisciplinary team. At minimum, this often consists of a doctor, nurse, social worker, and chaplain, and often others like a dietitian and physical therapist. And this interdisciplinary team works together to address the multidimensional needs that patients face during their cancer treatment, which in addition to physical symptoms are things like spiritual and existential distress, social support, advanced care planning, or caregiver needs. And palliative care is appropriate at any age and at any stage in a serious illness, and it can be provided along with disease-directed therapies from the time of diagnosis, as well as in the curative intent setting. So in this way, again, it's distinctly different from hospice or end-of-life care. So why is palliative care and early palliative care important in oncology? There have now been multiple randomized controlled trials that have been conducted over the last decade that have established that early palliative care improves patient outcomes for patients with advanced cancers. Early palliative care interventions have been shown to improve patients' symptom burden, mood, quality of life, as well as caregiver bereavement and distress outcomes. And early palliative care impacts health and quality outcomes. So it's been shown that patients who receive palliative care have less aggressive care at the end of life, less healthcare utilization, and in some studies, even a survival benefit. One of the first trials of early palliative care which showed these benefits was published back in 2010 by Dr. Jennifer Temmel and published in the New England Journal of Medicine. And this is the survival curve from that study that I show you here. This study tested an early palliative care intervention for patients with metastatic lung cancer, where patients received early palliative care within 8 weeks of their diagnosis and were followed by a palliative care team during their treatment. And the other arm received usual oncology care. And in addition to all of these outcomes here, they found that patients lived longer who received the palliative care intervention, on average about 3 months. And at the time, that was similar to a new chemotherapy drug. This was prior to immunotherapy and many targeted therapies. And so this was really paradigm shifting in the field and garnered a lot of attention. At the time, palliative care was just delivered at the end of life, closer to hospice care. And this was the first trial that really moved it upstream to test it earlier in a patient's treatment course. And now there have been multiple other high-quality randomized controlled trials that have shown these outcomes across different tumor types and in different care settings, and meta-analyses which support these results. So given this evidence base, ASCO and other major oncology societies, such as the World Health Organization and the NCCN, all now strongly recommend that patients with advanced cancer receive dedicated palliative care services early in their disease course, concurrent with active treatment. Yet despite this recommendation, early palliative care is still not well integrated into most oncology care settings. It's actually quite a challenging health problem. And in particular, we actually still, I would say, don't really know how to best do this for patients with breast cancer. And this is a critical area of future research. And one of the reasons that it's challenging in breast cancer is that the timing is actually really difficult to study when to best deliver palliative care and target palliative care interventions to patients throughout their entire treatment course. And this is different than other cancers, such as lung and GI cancers that have been studied in early palliative care interventions more thoroughly. So in breast cancer, we have heterogeneity in disease presentations, highly variable disease trajectories, and variability in breast cancer prognosis. And this is demonstrated nicely in this figure here, which is from a review published in JCO Oncology Practice on supportive oncology for patients with metastatic breast cancer, in which they show some of these varying different clinical courses that patients with breast cancer can have. And I think we can all think of cases where we have patients with very aggressive disease and high symptoms at the outset who have a wealth of palliative care needs, and then other patients who may have minimal symptoms at the outset and could have months or even years of good control before developing a complication, which could then be an acute or surprising event. And so the timing is really difficult to study in terms of figuring out how to best integrate early palliative care. There are also few palliative care studies that have focused specifically on patients with metastatic breast cancer. There are 2 that I'm aware of, which I show here on this slide. The first is an observational study that came out of UCSF back in 2018 from Dr. Mike Rabo. And this was a pre-post observational study of an embedded palliative care clinic model in which they looked at the period before the clinic was opened and after this palliative care clinic was opened in an advanced breast cancer clinic. And over an 18-month period, they were able to show increased referrals to palliative care. About 20% of 500 patients were referred over 18 months. And through chart review, fewer ICU stays in the last month of life, though this was limited by the retrospective nature of the study. My main takeaway from this study is they found that this palliative care model was well received by patients and oncologists. So it was very well accepted to have a palliative care clinic embedded in the advanced breast cancer clinic. And then the randomized controlled trial, the only one that I'm aware of in the metastatic breast cancer setting, just came out this year and was published in 2022 with Joseph Greer as the lead author. And this came out of Jennifer Temmel's group. She was the one who conducted that seminal trial over 10 years ago in lung cancer. Importantly, this trial focuses more on the end-of-life setting. It's a randomized controlled trial of a very structured 5-visit palliative care intervention in which they wanted to improve end-of-life care, their primary outcome being improved documentations of end-of-life care discussions. They recruited patients with metastatic breast cancer who had poor prognostic indicators, and they were able to show improvement in their primary outcome as well as increased receipt of hospice services. They did not show changes in patient-reported quality of life or mood symptoms, as has been shown in other early palliative care studies, but importantly, this was done more in an end-of-life setting. And so a gap does exist in metastatic breast cancer for how we should best integrate early palliative care for our patients. The high-quality randomized controlled trials that have been conducted in mixed tumor types did include breast cancer patients, but the numbers are low, and it remains less studied compared to traditionally more aggressive cancer types. I put that in quotes, such as lung or upper GI cancers. So a critical knowledge gap does exist regarding how we should best be integrating early palliative care for patients with breast cancer. And I want to emphasize here that my point is not that should we be integrating early palliative care for patients with breast cancer. I think that the evidence base for palliative care is very well established, and we can extrapolate from all these clinical trials that have shown benefit. I think the question facing us now is how do we best do this in everyday clinical practice, given the considerations that I discussed. And so I'm going to pivot on the next part of my talk to talk about big picture major concepts in the field of early palliative care of where we're heading to solve this problem. And I pick concepts that I think are particularly important in breast cancer for future areas of clinical innovation and research. The first is that we need to figure out how to deliver more personalized palliative care for patients with advanced cancers, and particularly breast cancer. And this concept focuses on delivering the right palliative touch at the right time to patients as unmet needs develop. And the reason this is so important in the field is that unfortunately there's a workforce shortage in palliative care. So in most settings, there are not enough palliative care clinicians or interdisciplinary teams to see all patients from the time of metastatic diagnosis and then follow them and screen them for needs throughout their entire cancer journey. And that's one of the reasons that palliative care still isn't well integrated across the entire country over 10 years after this original research came out. And this is also particularly important in breast cancer, in which I showed you the heterogeneity of different disease trajectories over time, that we need to figure out the timing better in breast cancer. So it'll be important to define referral criteria for patients of when to refer to palliative care, and then implement these with standardized assessments to screen patients for palliative care needs throughout their treatment. And any of these approaches need to be efficient, scalable, and very well integrated into our everyday clinical practice. And I believe that patient-reported outcomes, or PRO monitoring, is a tool that holds a lot of promise to do this, to screen patients for unmet palliative care needs during their cancer treatment. This is an area of future research and one that could be tailored to screen for unmet palliative care needs in patients specifically with breast cancer. The next major topic is that we need to pay a lot of attention to focusing how to implement palliative care for our patients. And this concept focuses on taking the evidence-based practices that have proven benefit in these randomized trials in a very structured, controlled setting and figure out how to implement them in our everyday clinics, in real-world settings. And this is really complex and, again, a challenge that's faced the field. And part of the reason is that palliative care is a really complex intervention. It's a complex biopsychosocial intervention. It's delivered by an interdisciplinary team of specialists. It often occurs over multiple time points and visits with a patient over a long period of time. And so it's very time and resource intensive, and again, has been difficult to implement 10 years out from the original evidence that came out. And so this is a major focus in the early palliative care field of research to identify core functions of the intervention, as shown in this figure, where they did some qualitative work in one of these randomized trials to understand the domains of that palliative care addresses. And essentially what they're doing and what they talk about in the field of palliative care is how do you determine what's in the syringe, like what's in the secret sauce of palliative care, and then take those core functions and adapt the intervention for specific patients or care settings so it can actually be implemented in real world. And we need to do this for our patients with breast cancer, again, understand how we should best be doing this. I think this will look different depending on the care setting you're in, the types of patients you take care of. I think what will be universal across settings, though, is that this really needs to be a team-based and collaborative approach between oncology and palliative care because of the interdisciplinary nature of palliative care and the multidimensional needs that palliative care addresses. The next major point is that we need to pay attention to advancing equity in palliative care delivery. The randomized controlled trials that I discussed, unfortunately, are really lacking in racial and ethnic diversity. Over 90 to 95% of the participants in those trials were white, and many of them were conducted within a small geographic region within the Northeast in Canada. And we do know that racial and ethnic disparities exist in quality end-of-life care and pain control for patients with advanced cancer, but less is still known about disparities in access to early palliative care. So it will be critical as we move forward, understanding how to best develop interventions in breast cancer for early palliative care, that we also pay attention to understanding how social determinants of health affect access to palliative care. Social determinants of health are defined as the conditions in which people are born, grow, live, work, and age. And as demonstrated in this figure, they include biological as well as non-biological factors, such as socioeconomic factors, cultural factors, behavioral factors, et cetera. A classic example would be smoking cessation, but you can also think about food insecurity or financial toxicity. Can patients access their medications? Can they get a ride to clinic in order to receive their chemotherapy? And so as we're developing these early palliative care models in breast cancer, we need to pay attention to make sure that we're recruiting patients onto clinical trials or participating in care models that come from diverse backgrounds, and then also measure social determinants of health and how they affect access to early palliative care so we can develop interventions that intervene on these factors and advance equity in palliative care access. And the last major point that I'll make for future areas of research is that we need to better understand how to measure the impact and quality of palliative care by measuring outcomes that truly matter to patients and families. This is a major focus in the field of palliative care, and the AAHPM, the American Academy of Hospice and Palliative Medicine, which is the ASCO equivalent in the palliative care space, has paid major focus to this in the last few years, and they just completed a 3-year project to develop new patient-reported experience measures that impact the value of palliative care. And with extensive patient and family input, they came up with 2 measures that focus on whether patients felt heard and understood and whether patients received desired help for pain. And this really shifts the focus from, I think, where a lot of attention has been paid in the last 10 years in palliative care on cost of care, healthcare utilization, even overall survival, things that are important but can be difficult to show and haven't been consistently showed across all palliative care studies. And I think that in breast cancer in particular, it may be difficult to ever show an overall survival benefit, for example, from early palliative care, again, because of the long disease trajectories of patients and heterogeneity, similar to our studies of adjuvant endocrine therapy. But just because we don't show an overall survival benefit from an early palliative care intervention in breast cancer doesn't mean that early palliative care isn't important. We need to instead identify upstream outcomes that we can measure and think about how palliative care is globally important to patients and families. And so what I propose here, it's in the future, I think we need to focus on patient experience measures and even clinician experience measures that palliative care may impact so we can better understand as we're developing models of care for moving the needle to improve palliative care delivery. So knowing these gaps in the field and areas of future research, I'd like to close my talk by addressing where we can start today as breast medical oncology teams. Monday morning, when you go back to clinic, what are the practical skills that you can start to apply to really start to move the needle in delivering palliative care in your own practice? And what I'd like to present are some practical skills that I apply in my practice that I learned in my palliative care training, which focus on screening and eliciting palliative care needs from patients, and also thinking very intentionally about when to refer to palliative care. The first skill or tip is to talk about palliative care early with all of your patients. To do this in a few sentences, and to introduce palliative care early as part of your team-based approach in oncology, which really helps build trust when you talk about down the road referring patients to palliative care. It also normalizes palliative care if you discuss it early, and so I'd really encourage you to try to do this very early on in your first maybe 1 to 3 visits. And these are some helpful phrases that I use to describe to patients what palliative care is, because again, it's a complex intervention. I spent 3 slides discussing what early palliative care is, and you need a few quick words to say it to patients. So I talk to patients and I say that palliative care is an extra layer of support during cancer treatment for you and your family. It's composed of a team of experts who help treat symptoms such as pain and other needs that are important to you during treatment. And the team works really closely with me to help make sure that we pick treatments that honor your values and preferences. And I also emphasize that palliative care is always delivered with the best possible treatments for cancer in order to optimize and provide the best outcomes from treatment. The next tip is to take a social support social history when you get to know a patient. And this often happens during your history and physical, when you get to the point where you're asking a patient about their health-related behaviors, such as smoking and drinking and who they live with and what they do for work and what they enjoy, et cetera. It's important to throw in a few extra questions to screen for social support needs. This will help you understand what social support a patient has, also caregiver support, as well as risk for developing social isolation during treatment. And patients who have these needs, you can utilize supportive care services or social work services within your team to meet these needs while patients are in treatment. And it also helps screen for patients who may develop the unmet needs in these areas during treatment, which is a valid reason for palliative care referral. So I'll often ask people or patients, who are the important people in your life? And also, do you have someone who will help support you during treatment? And these questions go a long way for screening for social support. This next set of questions helps me get at understanding if patients understand the purpose of their treatment as well as understand their prognosis. And I often use these during a scan review or when making a treatment decision when patients have to switch treatment or they have disease progression. And after presenting the information from the scan, I'll often pause and then open the door to a conversation by using one of these two top phrases here where I say, would you like to talk about what this means? Or what is your understanding of your situation now? And by allowing a patient to talk to you first about that, it really helps get a sense of where they're coming from, so then you can help explain things and fill in the gaps from there. Also, after talking through and having this discussion, usually when I present it, sometimes when there's more than one treatment to pick from, I'll ask patients, given the treatments that we discussed today, and thinking about your decision, what is important to you now? And that helps me tailor my recommendation to their goals in order to deliver goal-concordant care. This is the last slide I have with helpful tips and phrases, and potentially one of the most important ones, where I encourage you to think about asking patients for their sources of hope, worry, and strength. I've bolded my two top questions that elicit, I think, the most unmet palliative care needs for me by asking these two questions. I'm also usually the most surprised by the answers I get here. They're things that I couldn't have anticipated on my own, and you never know unless you ask. So I ask patients, what are you hoping for? What are your worries? And sometimes, where do you find your strength and comfort? And this is a great way to elicit unmet palliative care needs and think about reasons for referral if you detect distress in these areas. I want to pause and emphasize here that this is a very intentional approach. This figure here is of Tom Smith, who's an oncology and palliative care physician at Johns Hopkins, and he has these questions tattooed on his arm, which you can find in the educational ASCO handbook, these questions and others. And palliative care clinicians really come into a room when they know they're going to talk about coping or illness understanding or prognosis with a patient. They come into the room prepared with prompts like this in order to elicit these concerns from patients. So there's a lot of intentionality to it. It's difficult to integrate into your everyday clinical practice as an oncologist. You're busy, you have lots of things going on. I encourage you to bring this in on a cue card when you want to practice these questions. I keep these questions like on a note card in my pocket, and I bring them in. And then when it feels appropriate, you have it right in front of you, and you try one of these out. You say, what are you hoping for? What are your worries? And you have them there right in front of you. There's much intentionality to this. So pick a few skills to try. Practice one new skill at a time. For example, first try to introduce palliative care to your patients using those few short sentences. When that feels more comfortable, move on to maybe using some of these phrases about hope or worry. Pay attention to how it goes. You'll eventually adjust these phrases over time to use your own words, and be patient with yourself because all new skills require practice. Also, pay attention to when someone tells you that you did a good job. For me, it may be someone on your team, but often it's a patient. And it usually isn't at that visit, but it could be weeks or months later where a patient will all of a sudden tell me, it was really helpful when you said that to me when we talked about when I had metastatic disease, and you told me the news and you said this. And then I'll take that and use it with other patients. For those of you who want a deeper dive, this book, Mastering Communication with Seriously Ill Patients, is really a wonderful reference. It's my top book I keep on my desk, and I reference it all the time. It's written by some of the main communication experts in the field of palliative medicine. And what's nice about it is that it's a quick reference book, so you can look up just specific words or phrases. For example, they even have a section of during a scan review, and you can look up in 5 minutes what are helpful phrases that you might want to use and practice those. So I'll close my talk today by discussing when to call an expert. And this refers to, well, when do we refer to specialty palliative care, and to make a plan to do that. Similar to how you build a referral relationship with a cardiologist to manage cardiac-related toxicities of chemotherapy, or a pulmonologist to manage pneumonitis for immunotherapy, it's the same thing, that you really want to build your referral connections to your palliative care team. So reach out to them and get to know them to build that trust and collaboration as you're going to co-manage your patients together. And also ask about capacity and resources. As we discussed, there's a workforce challenge in palliative care, so it's helpful to check in with them to ask them, What is your wait time? Is it 2 weeks or is it 3 months? And when is it most helpful for you to start seeing patients with metastatic disease? Do you like to meet them at the beginning ideally, and then as needs develop, check in every 6 months? Do you not have the capacity to do that, and it's better that we work together and I'll kind of curbside you if I have concerns, and we'll discuss if it's a good time to refer? If you don't have an interdisciplinary team at your institution, I encourage you to reach out to your local hospice. Many local hospices have now developed early palliative care programs called bridge programs, where they deliver early palliative care in the home. And then lastly, I'll leave you today with my last slide with some referral criteria to consider for early palliative care. And what I'd like to emphasize here is that in addition to the severe uncontrolled physical or emotional symptoms that we all think about for referral, such as severe pain or anxiety or depression, that there are many other needs that patients have and develop during cancer treatment that are important and are very good and valid reasons to refer to specialty palliative care. I'd also like to note that the patient and family really are the central unit of care, and caregiver needs and family distress are good reasons to refer to palliative care, as well as help with decision-making, care planning, coordination, and social support. The palliative care specialists want to work closely with you in assisting your oncology team, and collaborating on complex patients is also a good reason for referral. So in summary, early palliative care is an evidence-based practice in oncology, and we need to figure out how to do it in the best possible ways for our patients with advanced cancer. Yet there does exist a knowledge gap in how to best deliver timely palliative care to patients with breast cancer, and arguably in many different tumor types. So future research will need to focus on how do we best implement palliative care, and these approaches need to be personalized, equitable, and also impact outcomes that are important to patients and families. Palliative care is an interdisciplinary intervention that requires a team-based approach in oncology and collaboration, and oncology teams can lead integration of specialty palliative care. Thank you.
Thanks for that wonderful talk, Dr. Kaufmann. We have time for a couple of questions, so there are a few microphones around if people have comments or questions. And while we're waiting for people to come to the mic, there's a few online that I'll mention. So one of the comments online is about, we know that there are racial disparities when it comes to breast cancer treatment, but there's also a gender bias taking place. And how do you think we can better work to engage men with breast cancer as well as our LGBTQ community into the breast cancer conversation?
I think that's a really important question. And I think it's true that a lot of this work, I may have even said women in my talk, focuses on women because that's the majority of the patients that we take into account. I think it's important to best understand needs from patients from diverse backgrounds, and that is a future area of research. So how do we best do this in different diverse patient populations? What we do know is that patients also benefit when their care provider is from a similar background and sometimes looks like them, or and that can be a helpful thing too. So I think also encouraging diversity and making sure that our oncology teams and our palliative care teams are made up of diverse providers would be an important thing there also.
Thank you. We have a question at the microphone over here.
Hi. Deborah Collier, patient advocate. I think, from the patient communities, palliative care is total care, right? It's total care for the person and their families. And so I'm wondering what kind of resistance you find within the medical community itself, and how can we as patient advocates help incorporate this more into a total care model?
If I heard the question correctly, I think what resistance do we see within the medical community from the provider perspective in referring to palliative care or incorporating palliative care? Yeah. This is a very complicated question. And what I want to emphasize is I think the lack of integration of palliative care is, there are factors on the provider level, but I would say it's very much a multi-level problem. Meaning there are barriers at the health system level, at the provider level, and at the patient level too, in terms of patients who don't realize what palliative care is and don't advocate or advocate for themselves to access it. So there's multiple different approaches we can take to improve early palliative care integration. I think on the provider level, what I have come to see in my practice, that part of it is it can be a lack of training, that oncology programs, I think up until recently, didn't well integrate palliative care skills and training into oncology practice, so it's not always second nature for an oncologist. Also, educating oncologists that sometimes patients do have very complex needs that require specialty referral, and that this really needs to be a team-based and collaborative approach, that it's not something that you should be trying to do alone. And this gets at the health system factors, that a lot of it is the intention is there, the skills can even be there, but you don't have the time and resources to do it in your busy everyday practice. And I find this challenging too, that when I walk into the room with my oncology hat on, I face different challenges than when I walk into the room with my palliative care hat on, meaning when I'm a palliative care physician, I have the time in the room to address these issues and the space, and I'm a different person in there in the room where patients may share different things with me as the palliative care physician, that when I ask the same questions as an oncologist of my patients, sometimes I can't elicit the same needs because I'm the one treating with the chemotherapy. And so I really have come to believe that this is a team-based and collaborative approach in which we really need to have oncology and palliative care specialists who are trained with different skills for each team. Oncologists should be delivering good primary palliative care in their practice, and then palliative care clinicians providing good specialty palliative care. And this really needs to be a team-based approach to address these issues.
Thanks for that. Question at the microphone?
Actually, I don't have a question. My name is Sheila Pettiford, and I am a MBC patient and an advocate. I just want to say thank you. I really think this was absolutely a wonderful presentation of something that we definitely need to have early on in this breast cancer journey. So that was not my story, but I hope it's somebody else's story. So thank you so much.
Thank you. That means a lot to me. Thank you.
I had one other question, and then I know we'll have to move on to our next speaker. One of the comments online that it makes me think wearing an oncology hat is, and you mentioned this a little, is when's the ideal time for a referral? So I think of patient burden with multiple appointments, a new diagnosis of MBC, and trying to help facilitate when's the most appropriate time.
Yeah, I think that timing is challenging, and the way that these trials were originally designed was to look at timing. So a lot of it looked at early palliative care referral within the first 8 weeks of a metastatic diagnosis. And I think that if we had unlimited resources and patients had unlimited time and money, right, that you would just have everyone see palliative care from the very beginning, establish and then follow them. But again, these models don't work for many reasons. And so there's a shift in the field to get away from the term even early palliative care, which I did use in this talk because that's the classic definition, but more towards timely palliative care, meaning referring patients when unmet needs develop during care. But there really has to be great attention spent on making sure that we're screening patients repeatedly for unmet needs as they develop, because the danger there is then that we miss patients that have undetected needs during treatment. So it's really trying to thread the needle, but I think developing these more personalized approaches to palliative care is really a big part of the way forward in the field.
Thank you very much, Dr. Kaufmann.
Thank you.